Hi, everyone. I'm Pinto, medical oncologist from Brazil. I was invited today to talk to you about my experience with our extended value stream using Lean in healthcare. I'd like to thank you for this invitation, especially William and Marcus. It is a pleasure to be here, and I hope that you will all enjoy this venue. I will share my screen right now, and I expect that you are watching what we're doing. So I will talk about this extended value stream in healthcare. I am a medical oncologist, head of the oncology at the Instituto de Oncologia do Vale. My experience with Lean goes from directing cancer centers as emergency hospitals and supporting other organizations, working as a senior advisor and faculty member for several organizations in Brazil and outside Brazil. I have no conflict of interest to declare. So the real problem for us is that medical error is the third cause of death in the US. And what causes medical error? Well, most kinds of process failure and errors can be treated with standard solutions. I mean, making problems visible, managing the adequacy of processes, reducing difficulty processes, improving capacity to solve problems. But what we will address today is process complexity and uncertainty. Well, things get complex when you have too many elements and you have too many variables going into a process. And it becomes uncertain when you are not sure what's going to happen in the future. And this is precisely what happens in healthcare. So complex service operations that requires safety and quality will always have some failure rate. That from Amy Edmondson in 2019, she estimated that as 2 or up to 5% failure rates. But I'm pretty sure that it's much more than that where I live and in the places that I work. We are going around 10 or 15% failure rates working with hospitals and with healthcare systems. That doesn't mean that we're doing harm to our patients in 5 or 15% of events, but we're failing most of the time. And what happens when you fail? Well, you have two dimensions in complexity. You have basically processes that are too complex, and you have to manage fail and variation in these processes. How to manage complexity and reduce fail and variation is one challenge. The other challenge is how to reduce complexity of the human interaction, how to reduce it and to make it easier to interact with humans. Well, communication complexity goes beyond what we are used to see. So we got 3 people in one interaction and we got 3 lines. When you got 5 people, you got 10 lines of communication. And it grows much faster than we would expect. If you got a team with 12 people, with 12 team members, you've got 66 lines of communication. It means that it can go wrong in 66 ways, different ways. And you've got 40, you've got 91. So communication complexity drives to a lot of variation. And you got into a complexity infinite loop. So variation leads to errors. Errors leads to inefficiencies. And it makes breakdowns and delays easier, which creates more variation. And you go on in this loop, creating more and more variation in your system. So this is one great example of what we were dealing back in 2011 with this kind of communication and process complexity that was not clear about what's going to happen. We named it that the board game for breast cancer patients in the hospital that I was running, the cancer division. It is a public hospital in Brazil. More than 50% of our patients are older than 60 years. 60% were living more than 1 hour drive from the hospital. And most of them were low-income patients. To get access to cancer treatment, more than 10 visits were needed, and you can get like 4 months to get to chemo. And we get that at that time, 300 new breast cancer patients per year in the hospital. And that goes this way, the complexity. You go to the triage system, see one breast doctor, here are their blood tests, scans images, and then checks tests, plans a core biopsy. After the core biopsy, you will get the diagnosis of cancer. It took 60 days to get there. Then you have to go to an anesthesiologist to plan a surgery, and 90 days are gone. When you see an oncologist and start your chemo, it's almost 120 days. And you've been in the hospital more than 10 times, driving more than 1 hour, waking up early in the morning. This kind of complexity created a lot of interactions around the system that was not clear. So what was our challenge there? What was the challenge? It's how to reduce this variation, how to better connect the dots to reduce variation in our flow. Well, our nurse Sheila decided to connect it back in 2011, and she created an A3 involving doctors, nurses, administrative personnel, and proposed some simple countermeasures. First, we got all appointments in the same day for all doctors. I mean, we got the breast doctor, the anesthesiologist, the medical oncologist working in the same day, available for breast cancer patients, but in a logical sequence, in a connected sequence. All doctors will have open slots in their agenda based on our historical demand. We had this historical demand. We knew how many patients will be visiting us per month or per week, and estimate a daily visit. The same for procedures, for CAT scans, for whatever. And the same for radiation and chemo doctors. And she created a daily huddle and a Kanban to manage this flow. So what happened? Patient got early in the morning. You got to a triage doctor, a medical oncologist, usually 7:30 in the morning. The doctor will decide if it's a breast cancer. He will get breast cancer with biopsy, without biopsy, and with biopsy. If it is a high-risk patient, not with diagnosis, she will go to tests. If it has biopsy and all other exams, she will also go to tests. Then, doing these tests early in the morning, the patient will see the surgeon early in the afternoon. And after that, the anesthesiologist for a pre-op evaluation. And later in the afternoon, a core biopsy. So up to 40 days of the previous cycles was put together in one day with just a single piece of paper. What we got? In 4 to 5 weeks, we got a surgery or chemo for those that were not candidate for surgery. And we were 53% faster. And 8 to 10 weeks chemo. And if needed surgery later, 15 to 18 weeks. So we reduced our time in almost half with just a single piece of paper, but putting together information, communication, and designing a flow for those patients. So it's a very simple strategy she decided to get. She reduced process complexity, uncertainty, redesigning the process through a value stream mapping. And she reduced the communication complexity and uncertainty through a daily management using a daily huddle. She was what we used to call the change architect. She is one of our change architects, and she is responsible for managing this flow to reduce complexity and uncertainty for all of those patients. If you want to read a little bit about that, you can go to the 5 Guiding Principles to Transform Healthcare. It's a white paper from the LGN. So what does a change architect do? It's actually projecting and executing a new design for the system, supporting a temporary structure, until we can have a permanent structure. So that's the idea behind the change architect. It is scaffolding a system to sustain it using the lean transformation framework. Think about, what do I need to do to improve my process? What capability I need to develop to understand how the problem will be solved, and how to manage its system. Focus on a single value proposition and base it in simple principles or basic thinking. We've been doing that for years in our organization, and we've been very successful. I mean, we improved our patient safety by 88%. We can have now our cancer patients on track for more than 80% of our patients, saved more than 60% of the waiting time for chemo and radiation appointments. Actually, we have no waiting time anymore for chemo or radiation appointments. 100% of our people are doing Kaizen, and we have more than 1,200,000 adopted ideas during this period. We're doing like 2 or 3 rapid improvement events per month and saving a lot of resources. I mean, we doubled our capacity. We freed up 12 days of productivity per employer per year since 2015. We reduced it like 80% of our inventory, 16% of energy consumption, and more than 40% of our overtime. So we've been successful in our journey, doing things like just what Sheila did. But the point is that solving our problems, or our cancer center problems, was only surfacing the system problem, because the flow management outside our boundaries was chaotic. Arrival time to access treatment was sometimes too late. I mean, some patients got to us too late to treat cancer. So how can we change the system? Well, reduce the complexity infinite loop was our idea. Reduce variation, that would reduce errors, that would reduce inefficiencies, and would reduce breakdowns and delays. So change the loop of complexity to a loop of positive reduction in variation, reduction in errors and inefficiencies, and breakdowns and delays, managing processes, and communication. So we started working on a public hospital around us in the city where we live. I will talk a little bit later about this city. It's a 400-bed hospital. It's an emergency and specialized care hospital with more than 300,000 emergency room visits per year. It's a crowded emergency room. And we've been working with them since 2016 with several projects supporting them, like emergency room project, the patient flow and supply chain, sepsis and clinical outcome, surgery and image center, noise reduction, and emergency room 2.0, and the what we called Kaizen shift. Some results, like the emergency room in 2017, we reduced the time for the yellow risk is patient with middle risk in emergency room, in a triage system in the system they use to define the risk of those patients. Door-to-door time, 43%. For the low-risk patient, the patient called blue and green, 25% door-to-door time. We also reduced a lot of money, eliminating a lot of unneeded supplies in the wards and in the ICU and the surgery unit, reducing the movement associated with the extra orders in the wards, eliminating like 18,000 kilometers per year walking, and reducing 10% of supplies expenditures per year in the hospital, in the whole hospital. They also saved a lot of lives. Like just in 2019, 180 lives were saved with the A3 designed to solve the sepsis problem, reducing the hospital overall mortality by 4.5%. It is amazing result for those guys, and they are doing a great job still, and they are still evolving. But we decided to go deeper into the system, because we live in a city that has 220 1,000 inhabitants, and this is one hospital that we've been working with, but we have 45 primary care units and 12 specialized care units, 8 emergency rooms. The hospital that we've been talking is this 400 beds hospital, and there's another huge emergency hospital, but it's only emergency hospital. And there are other hospitals that are not into the system, but provide cares to the system, like specialized cancer hospitals that I will show you a little bit later in this presentation. So we started to working with the whole system in 2018. And this is another example from the other emergency hospital, where they have like 240 emergency visits per year. We created just a simple idea: fast track for blue patients, for low risk patients, and standard work for doctors, standard work for nurses, and huddles. We reduced door-to-door timing 31% for those patients, 31%, from 4 hours door-to-door to 2 hours and 45 minutes. And this is a picture of what I was looking for before and after. The same happened with blood sampling collection in primary care units. They doubled the daily capacity for collecting blood samples, and they just reduced it to 1 to 7 days. These are from go 1 to 7 days to 1 day, providing blood test results for those patients. That one before was taking like 7 days and 120 days to get access to blood tests. And we also did a great job with the supply chain. That was how the supply chain was provided before we started planning and working with them, redesigning the flow for the supplies in the hospital. And they got it like once a month, and it was crowded. They had to work a lot to put things together, and they had no resources to make it. They got a lot of waste associated with that, because they got, well, supplies. Let us supply once a month, and the result was wasting, a lot of waste. So we changed it like a weekly supply, and this is the new look of what we're getting. And it's getting better because it's saving money. They save it like 65% of the supply, of the amount of money spent in supply chain in primary care units, and almost 89% in the logistics of the supply chain, saving in 2019 more than 4 million reals in savings. That was converted into patients. And this is the before and after. We have like a lot of empty rooms in the primary care units now, and a lot of people smiling about how could I live with that amount of stuff and have no idea that it was not useful. The good idea is that these empty rooms become Obeya rooms, and now they are discussing their practices, and they are discussing what they're doing, and they are creating A3s and redefining the way they make flows and redefining the way that things are going. So in from 2019 to 2022, we've been trying to create what we call a model primary care unit, and we are getting some good results with this primary care unit as well. So nowadays, this primary care unit can see 60% of their on-the-door demand, patients that are arriving on the door calling for a medical appointment, in the same day. And the median for those is now 14 days. I mean, if you're not coming, walking into the primary care unit and have the appointment in the same day, because it doesn't mean that you have to have the appointment in the same day, and some patients will just come in to return. The median time for this practice from this unit is 14 days, comparing to 28 days from the rest of the system. We've been working with them for a lot of time, but we got a lot of stuff happening during the pandemic days here, like lockdowns and vaccination period, and we were not able to clearly measure what was going on until the end of 2021, from October on, when we are stable with vaccination, and we could compare the difference between what what this pilot primary care unit was doing and what we're doing with comparing with all others. But the difference is we reduce it by half the waiting time to have access to primary care. But we're also working with the cancer. I'm a cancer doctor, so we created a project in 2019 to reduce waiting time to get access to cancer, grounded in 4 major actions. We redesigned the process. So remember, we are reducing complexity in the process, creating value stream mapping. So we are connecting providers, and we are using daily problem solving for the teams, and we are managing flows using visual tools like this board for cancer patients. They're looking for prostate cancer here. So this board was a daily management board for cancer patients, prostate cancer patients waiting for doctors. And we got more patients than board at that point. The second great major action that we did was daily management. So flow redesign and daily management. Daily huddle with primary care, secondary, and tertiary care providers, weekly strategy deployment huddles, weekly huddles with oncology care, and bi-weekly huddles to evaluate global performance. We created open communication channels, a hotline for the flow manager with the 46 primary, other secondary care units, specialized support by phone with a specialized physician, an oncologist, and a special flow for emergency access. So patients needing emergency care would have the access immediately. And we redesigned flows inside hospitals. So this is one example of how we redesigned the flow in one cancer hospital. That is the main hospital for cancer patients, more than 2,000 new patients per year there. We created just a queue management, redesigning the flow, creating 4 product families like chemo, fast and regular track, oral chemo, and follow-up patients. New flows, 6 months training. They increased 10% their personnel, just 10% of their personnel. And from 2017 to 2018, they more than doubled their capacity. They were able to double their capacity, redesigning their flow. The same happened with the radiation oncology system. Same idea, fast track, regular track, and special track. 4 product families, fast and regular track, breast cancer, prostate, fast and regular, breast cancer, and other, and emergencies. So from 2008 to 2020, cancer diagnosis increased substantially. Access to care before 60 days of diagnosis almost doubled. Time to access breast cancer immunohistochemical exam dropped from 38 days to 4 days. And the hotline answered more than 2,500 demands coming from primary and secondary care providers. And this is a sample of the weekly huddle, the leadership weekly huddle from the project. And this is the oncologist doctor that manages the whole flow. So that's the numbers. Back in 2016, like 560 patients total diagnosed with cancer against 1,400 here and 1,100 in 2020. But most important of that, we were able to treat those patients in less than 60 days. 2/3 of those patients, more than 1,000 of those patients, get access to care, means surgery or chemo or radiation or whatever, in less than 60 days of the diagnosis. And comparing to what happened to Brazil, during the pandemic, we got 77% reduction of cancer diagnosis in 2020, 77% in Brazil. Fortunately, not as good as but we got just 20%. I mean, we were able to sustain access and care for our patients and provide them good quality care, even during lockdowns and the terrible crisis that we were living during the 2020 crisis. So at this point, we are sure that reduced process complexity and communication complexity is still working for us. We are developing change architects, leaders that are capable to manage flows and to manage daily management, to manage our daily health, to make it work in the way that it's really, really valuable for our patients. And we are using just our 5 guiding principles that don't wait for the CEO really means that you are the change agent. Your CEO will not have time to support your process. Don't wait for him. Ask for support, show appreciation, but don't wait. Start changing your system. You are the guy responsible for change it. Have a clear aim and purpose is vital. What are you going to do next? What's your next move? That's the question that you have to do to improve your system. This problem must be a problem affecting you and your customer, your client. So you must be the owner of the problem, hand in hand with your patient. Ask for help, learn on the job, use paced learning. Mass training will not be very helpful. Inventory of knowledge is not very helpful. So everyone must have a clear understanding of what's going on and what you need to do at this point, or what you will know at this point. Learn from your peers is the cross-pollination idea. Learn from your peers and understand how good looks like. Go see and learn, because that's your journey. It's a learning journey, yours, from your people, from your team, together. Because Kaizen means change for good. And the idea behind that is that we're changing for good. Use your knowledge for that. So thank you. I will answer questions right now, and probably I will answer those questions live with you at this point.